endometrial cancers, and actually most gynecologic cancers, aren't ones that medical oncologists see very often. And when they come to our door, it's always an issue of whether or not there's data and whether to even recommend treatment, and if so, what kind of treatment to recommend. We, in gynecologic cancers, do utilize chemotherapy, we utilize progestational endocrine therapies, we utilize radiation therapy, and sometimes trying to make sense of who should get what and if they should get that is an issue. So I think the first part, which reflects what's going on a national stage, is to really understand who should get chemotherapy, who should get radiation therapy, and the only way really to do that is to understand a risk stratified approach to endometrial cancer. And so the genesis of that was to really highlight that not all women diagnosed with endometrial cancer face the same risk of recurrence and face the same risk of death from their disease. There's a group who should not receive treatment at all, and that's that low risk group, grade 1 cancers, limited to the lining of the uterus without any muscle invasion, no evidence that the tumor has gone into the blood vessels. Those women do not benefit from chemotherapy. And again, as I stated, there is data to suggest that the risks of radiation therapy outweigh any potential benefit of treatment because these women survive very well. The majority of them will, without any treatment at all. Then you get down to the intermediate risk patients, and that's where the stratification has occurred, trying to identify in these women where the risk isn't as low as one would like, but it's nowhere near as high as others, who should get anything at all. And what we've done on a national stage is looking at this group of women with intermediate risk, so grade 2 cancers, some will include grade 3, lymphovascular space invasion, deep myometrial invasion, and age. Who of these women should get treatment? And we use age to help identify those women in high intermediate risk. So older women over 70 just takes one of those factors to classify as high intermediate risk. Women under 50 should have all three factors to sufficiently classify them as having a high intermediate risk. Now, if you're then identifying those women who should get something, the question is, what kind of something are you talking about? And that's where we favor radiation right now, because we want to treat for a risk of a local recurrence. However, radiation, and I did not go into this in the presentation, radiation will reduce the risk of a local recurrence, but has no difference at all in surviving this cancer.